warmer here than it is where I'm from, where it's the middle of winter. So today I'm going to talk about complex hernias and how we deal with it. I have no disclosures, other than my goals with this talk today are to define complex and loss of domain hernias, which makes up a lot of my practice. We're going to discuss some of the unique challenges to these types of hernia repairs. I'm going to discuss some tips for success, and then really talk about some of the postoperative care that's unique to these very large hernias. So what defines loss of domain? I think in reality, when you see it, you know it. You walk into, your patient walks into the clinic and they kind of surprise you with maybe a very large hernia. This was an excerpt from 20 experts across multiple societies, including the AHS, the EHS, and various hernia societies, that I think probably best describes these hernias, in which simple reduction of discontents and fascial closure cannot be achieved without additional reconstructive techniques. And then there's also a significant risk of complications. So I think that's something we really need to understand. We also have other definitions of loss of domain that characterize the hernia sac volume in relation to the abdominal cavity volume. This was described by Tanaka et al., which is greater than 25%. But also we have other ones that kind of try to better categorize this in terms of numbers-wise. But I think while these things kind of help understand these hernias are large, I think the earlier definition lets us know that these aren't just the same straightforward hernias, and that there is some amount of physiologic consequence to fixing these. And so I think one of the most challenging things is it is very hard to define, because there truly is no one size that fits all. A very big hernia in one patient might not be the same as a large hernia in another patient. There are multiple patient factors that play a role. What caused that hernia? What repairs have they done? How compliant is their abdominal wall? Do they have soft tissue problems also that you have to worry about? And all of these can be very challenging to measure. So we're going to look at 2 CT scans. So why are these repairs so challenging? I think first off, when you are looking at these patients, you're probably not the first surgeon that they've seen. They often have had multiple previous operations. In reality, you are going to change their physiology very acutely in the OR. These patients often have had issues being optimized, because you can imagine a large portion of your viscera is outside your abdominal cavity. Being active, moving around, causes significant problems. There's also a lot of skin and soft tissue issues that can become associated with a significantly large hernia. And these are technically complex procedures. And so I'm going to show you 2 CT scans that kind of discuss how each of these repairs are different. So this first CT scan, you can see this lady has a large loss of domain incisional hernia. This is all of her flank. So she has completely ruptured the right side of her abdominal wall. The majority of her viscera is outside her abdominal cavity, but what you do notice is that she actually has reasonable soft tissue. When we look at this other CT scan, again, a very, very large loss of domain hernia. She has 1 kidney out there. You can see how thin her skin is. So when we approach these, we know that we are going to cause significant differences in each of these patients, even though the entirety of the viscera, for the most part, is outside in both of them. So let's talk about preoperative optimization. So when I meet patients in clinic, I discuss to them, basically your abdomen is a suitcase and it's over full. And I've got to try to get what you've got on the outside tucked in on the inside. And I think there are 2 ways to do it. Number one, you can unpack some of the stuff that you put in there, which, is always the goal, or you can buy a bigger suitcase. But a lot of the airlines say this is all you get. And at the end of the day, you're trying to get all of that stuff into a very, very small cavity. So let's talk about how we achieve these goals. So how do we take clothes out? I think weight loss is very key and gets you to a point in these patients. Ideally, bariatric surgery is great for some patients, but obviously if you've had a multiply reoperative abdomen, maybe that's not something that you can get. I think the GLP-1s have made a significant difference. And in general, I think a lot of patients are motivated if you set a reasonable expectation. You can see this patient, the first kind of slide, even on the scalp films, had gotten a sleeve in between these 2 procedures. So it does significantly change the amount of volume that you can get in. And I think this is very helpful, but I think that oftentimes we can't get patients down to a BMI of 30. They have so much stuff on the outside that getting them to a point where you can hopefully get things in is helpful. But I would say the standard that I utilize for these patients is a little bit more flexible than some of the other patients. I think visceral reduction, you're lucky if you have to do a concomitant maybe colon surgery, but I would say is very, very aggressive for these lots of domain hernias. And again, when you're thinking about repairing these, you're changing a clean case to a clean contaminated case, which can significantly increase the morbidity in an already very morbid operation. How do you make your suitcase bigger? Well, we know that preoperative Botox is very, very helpful. And the way it works is it increases the muscle length by decreasing the muscle thickness. So you can see here that when they injected Botox, not only did the muscle get longer, but it also got a little bit thinner, and therefore made our hernia defect a little bit smaller. I typically do this in patients which I think that I may be able to get closed, and we do about 150 units on each side. The other thing that you can do to make your suitcase bigger is to do preoperative hemoperineum. And I know this is very common in places not often in the US, but there is a significant amount of data that shows that when you're using preoperative hemoperineum, you can increase the abdominal cavity and decrease the ratio between your hernia sac volume to your abdominal cavity volume. I think one thing that's important to note is this is not benign. I tend to use Botox a lot more frequently because in general, Botox isn't bad. It's very, very safe for our patients,